Good evening, everyone. My name is Michelle Galazewski. I'm a Partner Relations Director with Eversight, and on behalf of everyone at Eversight, I would like to thank you for joining our fourth program of our webinar series, DALK Pearls. Before we get started with tonight's program, I would like to remind everyone of two additional webinars that have been added to our series. Tomorrow evening, we will cover the topic of reopening your practice with an effective communication plan. And on Wednesday, June 3rd, we will cover the impact of COVID-19 on ocular disease and donor tissue. It's not too late to register for either of these great programs. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you may do so by typing your question into the Q&A panel at the bottom of your screen. We will address all questions at the end of the presentation. At this time, I would like to introduce our speaker for this evening, Dr. Nambi Nallasamy. Dr. Nallasamy is an assistant professor of ophthalmology and visual sciences at the University of Michigan Medical School, Kellogg Eye Center, Michigan Medicine. He is fellowship trained in corneal and refractive surgery, and his research interests include endothelial disease and novel surgical techniques for endothelial dysfunction, high-risk corneal transplantation, and visualization, diagnosis, and therapies for ocular surface tumors. Dr. Nallasamy, thanks for joining us. You can begin.
All right. Thank you so much, Michelle, and thank you, everybody, for joining us tonight. I know you are probably very, very busy right now, given all the changes related to COVID, and I appreciate your taking the time to join us for this discussion of DALK and some pearls related to DALK. So why don't we just go ahead and dive in. So we'll start by just talking about what DALK is. I'm sure many of you are already quite familiar with what DALK is, but it's just to recap, it's a partial thickness corneal transplantation involving primarily the donor corneal stroma, but also Bowman's layer and possibly some of the epithelium. It leaves the host Descemet's membrane and endothelium in place, and it's typically indicated for diseases that involve the corneal stroma and have an intact corneal endothelium. So over there on the right, you can see just a schematic of a variety of different types of keratoplasty with DALK up there on the top right. So the first question that I think we should tackle is why consider DALK, or why add DALK to your practice if it's something that you're not already doing? And for those of us who are doing it, just to be introspective about why it is that we do it. So head to head with penetrating keratoplasty, DALK has a number of very nice characteristics. So one of them is that it has no risk of endothelial rejection because we're leaving the host cornea's endothelium in place. And the result of this is that it decreases the overall rejection risk for patients undergoing DALK to just 0.28 times that of penetrating keratoplasty. So that's a really nice benefit, especially for some of our younger patients. DALK, at least in theory, will maintain a formed chamber and as a result has a lower risk of suprachoroidal hemorrhage than a penetrating keratoplasty. It also allows us to utilize tissues that don't have an ideal endothelial layer. And so since we're talking on behalf of Eversight tonight, I think it makes a lot of sense to be thinking about how we can best utilize our tissue, and the idea of being able to generate two tissues out of one donation, one gift, is really quite interesting. Certainly, we'll get into the cost-utility analysis as well down the road in this talk, but it does have a favorable cost-utility compared to other procedures. DALK certainly has a stronger wound and a lower risk of post-op open globe injury, and as well as a lower risk of development of glaucoma due to maintenance of the angle structure, as well as a lower risk of cataract because there is no open sky. Certainly, DALK versus ALK, or anterior lamellar keratoplasty, is a worthwhile consideration as well. I think there are definitely times with anterior stromal scars when we might consider just an anterior lamellar keratoplasty as opposed to a DALK. But there have been studies that show that DALK develops less interface haze, and as a result tends to have better visual outcomes or visual potential. So, why is it that people are hesitant to try DALK, considering all of these positive aspects to it? Well, the simple explanation is that PKP is really less technically demanding. especially for optical indications. It's less time consuming. There's no stromal dissection. There's no dealing with the possibility of a perforation. And there are no interface issues. So it's possible to get viscoelastic or heme in the interface when we're doing a DALK. And PKP just doesn't have that concern. And there's no concern about having to leave stroma behind for these patients. So in addition to that, PKP also has a wider range of indications and is kind of a more flexible surgery in some regard. But for your young patients with optical indications for surgery, DALK is certainly worth considering. And primarily you want to be thinking about those risks of rejection, cataract, and glaucoma. So hopefully you all are at least interested in considering DALK if you're not already doing it. And so why don't we just kind of dive into what a DALK entails, and then we'll start to dissect a little bit further. So there are kind of two approaches to doing a DALK, as I'm sure you all know. Stromal dissection, in which we do a manual or automated removal of the anterior portion of the stroma. And then there are these cleavage separation techniques. So the most commonly thought of is the big bubble technique of Anwar and Teichmann. But you can also use viscodissection or viscoelastic to make your dissection of the Descemet off of the posterior stroma. So that's kind of the main idea behind a DALK. But how did we get there? So it's actually quite a long history, and anterior lamellar keratoplasties actually started over 150 years ago. And there were some dedicated instruments that were initially designed for stromal dissection, but Hallerman in 1959 was the first one to perform a deep stromal dissection that was close to Descemet. Anwar in 1974 removed donor Descemet and endothelium to create this smoother interface and what he thought would provide a better visual outcome. And then Arkila in 1984 used air injection to help create this pneumodissection. And in 2002, Anwar and Teichmann coined the big bubble pneumodissection technique. So what are the patients in which it makes sense to try a DALK? So certainly patients with ectasias of various sorts like keratoconus, pellucid, or an ectasia following refractive surgery. But stromal scars are also a great indication for a DALK, so post-HSV or VZV keratitis or post-corneal ulcer patient. And again, thinking about those young patients who have experienced all of these issues, those are really ideal candidates to try to leave their angle structures intact, as well as try to leave their lens intact. Corneal stromal dystrophies can also be a nice indication for it. Avellino, lattice, and granular typically do pretty well with a DALK, but macular dystrophy tends not to do quite as well. There tends to be deeper involvement and recurrence. So what are some less common indications for DALK? Well, dermoids certainly can be an indication if you have a significant loss of corneal stroma as you're excising your dermoid. An anterior corneal infection in a therapeutic manner could also be a consideration for DALK. Not something that I typically do, but certainly worth considering if you're trying to get ahead of an infection. Sorry about that. Our motion detector is turned off here, so I'll try to make sure that I'm moving around enough. So you can also think about a DALK as an alternative to temporary keratoprosthesis and penetrating keratoplasty surgery. So you may be doing a lot of combined surgeries with your retina colleagues and needing to do a temporary keratoplasthesis in order to provide them with a good enough view. But what you could do instead for certain patients is to consider doing a stromal dissection to get down to a level at which you have clear stroma posterior to it. And then just place viscoelastic onto that dissected plane and either just leave the viscoelastic in place or to refine a contact lens to the size of your dissection and place this over the viscoelastic. And oftentimes that will actually provide a good enough view for your posterior segment surgeon to do their portion of the surgery. So something to think about, and another possible indication for DALK, although it is not something that we commonly think about when we think about DALK. So when should we think twice about starting a DALK on a patient or attempting a DALK on a patient? So obviously we don't really want to do a DALK on a patient who has an impaired endothelium or Descemet membrane, so your posterior corneal dystrophies like your posterior polymorphous or your Fuchs dystrophy. But you also want to be thinking about patients who might have had a healed perforation, prior RK, which can sometimes involve a prior perforation or perforation of Descemet's membrane, or patients who have had an episode of hydrops. So a lot of our keratoconus patients, especially our younger ones, may have had an episode of hydrops. And so really evaluating, especially if there is scarring anterior to that hydrops, really evaluating Descemet's membrane by considering getting an CT is a good idea, because it can help you alter your approach to the surgery. So you can either decide not to do a DALK in that situation, or you can think about doing a manual dissection to avoid blowing out your Descemet when you try to do your big bubble. So how do we do a DALK? We're going to try to cover some of the basics of technique, management of some of the intraoperative complications, some routine post-op management, and management of some of the post-op complications. And at any point, if there are questions, please do send them in, and we'll try to have a discussion toward the end. So let's get started just with an overview of our big bubble technique, which is kind of the most standard technique out there right now, or the most commonly performed technique out there right now. So we start by doing just a partial thickness trephination. Different people have different recommendations on this. Some people will trefine just down to 50%. Some people will try to trefine down to 85% depth. Really just depends on your approach and how comfortable you are with the pachymetry data that you have. So if you have a really accurate pachymetry map, depending on the modality that you've used, then great. If not, then you may want to think about going a little bit less deep with your trephination to avoid your trephination causing perforation of Descemet. Then a lot of people will do a superficial stromal dissection, remove the anterior stroma, usually about the anterior 50% of the stroma. Some people will try to leave that anterior stroma in place in the thought that that anterior stroma being left in place actually provides some additional strength to the anterior cornea and forces the air that you inject down toward Descemet as opposed to up toward the anterior stroma. You can do it either way, and people certainly do use both approaches successfully. Then the next step is usually to try to go a little bit deeper than that 50% layer, usually about 50% of the residual stromal bed or deeper, and to do an injection of air or sometimes viscoelastic in order to separate Descemet from the posterior stroma. Oftentimes, people will then put in an air bubble into the anterior chamber. You can choose to do that prior to doing your big bubble with a paracentesis, or you can do that after you do your big bubble. You just want to be very careful if you're doing your injection of the air after and making your paracentesis after your big bubble to not go in too far to avoid perforating Descemet membrane, which is peeled back away from the posterior stroma. So then after you've done all of this, you can do your slash, which is maybe one of the more nerve-wracking portions of the surgery, trying to make sure that you avoid nicking Descemet, but get through the posterior stroma so that you're able to access the space between that pre-Descemet space. A lot of times folks will inject viscoelastic materials. Some folks don't do that, and my preference is to inject viscoelastic but into that space to push back Descemet. But you can also do this dissection of the posterior stroma without it. Oftentimes so my preference is to divide the posterior stroma into quadrants and remove it as such with viscoelastic protecting Descemet. And then bringing back in a graft after having putting in the donor tissue after having removed the donor Descemet and endothelium and suturing that in place is how you wrap up the surgery. I'm sure many of you are familiar with all of this already, but I just wanted to make sure that we went through all the steps so that you'll see what we're talking about as we go on through the talk. So this is just another view of that same information, but in actual surgical context. So you can see our trephination, the initial dissection using a crescent blade to remove that anterior stromal cap, injection of the air. Typically, I prefer to use a cannula that has the port aimed downward, usually the Fogla cannula for DALK, in order to make sure that the air is being directed in the appropriate direction. You see this nice big bubble forming with this ring of whitening around it, and we'll talk about what that means later on. And then the slash, the injection of viscoelastic, and proceeding with the formation of quadrants. You can see the air bubble within the anterior chamber, removal of the donor Descemet and endothelium, and the suturing into place. So I thought this might be a good point to start with a video, just showing you some of the basics of how Dr. Fogla actually performs a DALK. And we'll kind of use this as an example of what a standard DALK technique nowadays tends to entail, and then we'll talk about some of the variations and what I might do differently. But obviously, this is a fantastic case. So Dr. Fogla likes to start by actually marking the cone, which I think is a really nice idea because it gives you a little sense of depth. So for those of us who may not have an anterior segment OCT or a slit beam view available on our operating microscope, having that extra perspective from marking with a marking pen is kind of nice. He will then remove the anterior 50% of the stroma with his crescent blade. Yep. We'll try to fast forward through this a little bit. He uses a pointed dissector then to create a little plane, usually aiming about 50% of the residual stromal bed. And then using this posteriorly directed cannula injects air to try to move Descemet off of the posterior stroma. You see this nice approximately 8mm ring with a white annulus at the edge, and that's a nice indication of an excellent big bubble. This paracentesis to release the intraocular pressure, as well as sometimes my preference is to put in an air bubble at that point. Here he's just gone straight in, made his nick. So one thing that you can do here, which I think is a nice trick, is to, instead of just making your slash, is to put some viscoelastic on top of that posterior stroma prior to making your nick. And sometimes what I find is that viscoelastic on top of the posterior stroma helps to maintain some of the air in that interface so that you don't have a very quick release of air and have a rush of Descemet right up to your blade. So that can help you prevent some perforations that might otherwise occur. So at this point, he switches to using his trifacet spatula, and I use a similar instrument here. You can use a blade to cut down onto your trifacet spatula to make your quadrants. You can alternatively use scissors to do that. My preference is to use the trifacet spatula. I feel that it provides a really nice protection, moving Descemet away from the posterior stroma and protecting it while creating a nice platform onto which I can use my blade, usually a 75 blade, to cut down onto it and create my quadrants. And then using this these special DALK scissors, which have a blunt lower tine, which is longer than the superior tine. You can very safely dissect off that posterior stroma. And that allows us to then proceed to suturing in our graft. So you do see a couple of little fibers there. That's often inevitable, but as you lubricate that surface, you see a nice crystal clear Descemet there. We bring in our donor tissue after having removed donor Descemet and endothelium, and we'll talk about different ways to do that in just a moment. This is something that I like to do as well. I like to place my RK marker for suture guidance actually over the donor as well as the host. So oftentimes when we're doing a penetrating keratoplasty, we don't have that luxury. We have to do our RK placement prior to doing our trephination, and so we don't have marks that go that extend onto the donor. Here we do have luxury, and we're able to mark both the donor and the host, which is a nice opportunity to ensure that we have a very consistent suture all the way around. So here he's using a combination of interrupted and continuous sutures. My preference is to do interrupted only, but to each their own. All right, so potential intra-op issues. we'll talk about. So right now, we'll just talk about perforation. So perforation is obviously what most of us are concerned about. Perforations can occur at any step. And unfortunately, a lot of times they can force us to convert to a penetrating keratoplasty. But there are several situations in which it doesn't preclude completing the surgery. So if your air bubble is lost, you can actually replace that air bubble if you need to, or you can reinflate the chamber. And if you have a perforation, you can also try placing an air bubble at the end of the case to aid in that attachment of Descemet's. Otherwise, we can sometimes get a double anterior chamber, which we'll talk about a little bit later as well. But really, perforation, again, can happen at any step. It can be intrephination, so you really want to look carefully at that pachymetry map to know exactly how deep you want to trifine. I typically try to aim for somewhere around 75 to 80%. Some people will go a little bit deeper. It can certainly happen during stromal dissection, as that's one of the more challenging, if you're doing a manual stromal dissection. If it's your anterior stromal dissection, typically no. Certainly during bubble formation, if you become a little bit too aggressive and you try to go a little too far out to the periphery. And then certainly during suturing, that's a possibility. So if you operate with residents and fellows, you do want to make sure that they're aware of that potential complication when we're doing that suturing. Another potential intraop issue is to not be able to get a big bubble. And so that's certainly possible. It certainly has happened to me. And so you might want to consider leaving the stroma, some residual stroma in place and doing as much of a manual dissection as you can. You can also try leaving that anterior stroma in place, that cap that we were talking about, so that you can try to force the air downward toward the endothelium. Another thing that you can think about is your injection depth. So it is quite challenging, especially if you don't have an anterior segment OCT, an intraoperative anterior segment OCT, to really be able to gauge your injection depth. But that is something that you want to be thinking about. And using that rule of thumb of removing the anterior 50% and then trying to go to a depth of 50% of your residual stromal bed can be very helpful. Thinking about your injection depth, though, it's important to know the different bubble types and what you're shooting for. So there are a couple different types of bubbles. Actually, there are more than just two, but the ones that we commonly encounter are either a type 1 bubble or a type 2 bubble. Sometimes it's a 3 bubble, which is kind of a mix of the two, 1 and 2. So a type 1 bubble is what we saw in that previous video that we watched. So the type 1 bubble typically occurs anterior to Dua's layer, and it results in a bubble that's approximately 8 to 9 millimeters in diameter and has this white annulus at its margin. Usually there will be some residual collagen fibrils, and you can see that in that image there on the right, just above that type 1 marking. So you see some residual collagen fibrils there. They disappear when you lubricate, but if you dry your corneal surface, the posterior stromal surface there, you will see some of those residual collagen fibrils. The nice thing about getting a type 1 bubble, though, is that you get a stronger host bed, and so you're less likely to perforate and can be overall a safer surgery without substantial difference between visual acuity postoperatively compared to a type 2 bubble. So studies looking at when type 2 bubbles form versus type 1 bubbles have shown that a type 1 bubble typically occurs with an injection depth somewhere around 100 microns of residual stroma. So that's something you've been thinking about. If you're going a little bit more aggressively to get closer to Descemet's, you might end up with a type 2 bubble, especially if you're able to get down to somewhere around 50 microns with your injection. So a type 2 bubble, unlike a type 1 bubble, is just anterior to Descemet's membrane, so just inferior to Dua's layer. And so a type 2 bubble typically has a clear margin, as you can see there down in that lower picture on the right there. And it typically extends to the periphery, so it can be anywhere from 10.5 millimeters all the way to Schwalbe's line. What's nice about it is you get this beautiful clear Descemet's that's bare, but it is much easier to perforate, and so you do have to keep that in mind. So if you see that you have achieved a type 2 bubble, you may want to be extra careful when you're doing your dissection. Really think about using that viscoelastic to push away that bare Descemet's as you're doing your dissection of the posterior stroma and creating your quadrants to remove them. So Another thing that you can think about, another thing that may happen is that you just don't get your big bubble and you need to try it again. You just get a lot of emphysema. And so let's take a look at a nice example from Susan Jacob. So she starts here with an injection. Here she's just using a needle with the bevel down and getting a lot of tissue emphysema, so presumably just a little too anterior. Getting a lot of tissue emphysema, but not really, really no bubble, no big bubble there. So what's nice is that she just pulls out, finds an area where there is no tissue emphysema and she has a clear view, and then restarts her injection. And then you can see slowly, with another little repositioning, a bubble form. So now you've got your big bubble, and you can go at it again. And now you can do all the rest of the steps that we were talking about. So paracentesis and moving on. Here is an example of a surgeon who actually leaves the anterior stromal cap in place and then does that anterior stromal debulking after the injection. But I think this is a nice reminder that even if you don't get your big bubble on the first injection, it doesn't mean that you need to give up and convert to a penetrating keratoplasty. Just find an area of the tissue that isn't emphysematous and go ahead and try again. So moving on. Let's think about some of these patients with prior histories of perforation. So if you were to do a big bubble in a patient who had a prior history of a corneal perforation, RK, maybe hydrops, you might have prior violation of Descemet's, and that patient may not be able to withstand a big bubble. And so in order to deal with that, you might think about, from the start, trying to do a manual dissection approach. And so I just wanted to show you some examples of what that look like. This is, again, Dr. Fogla. This is a post-RK patient, and that can be quite a challenge. So here he's just putting in an air bubble just to identify, and he's using a really blunt dissector here to remove the anterior stromal cap. And this can be a pretty involved process. I do find that using a sharper instrument like a Crescent blade tends to provide a much quicker dissection of the anterior stromal cap off. So that's completely up to the surgeon's preference, but something that's quite reasonable to consider. So what I like here that he does is that he uses a small hook and then these special stromal pocket forceps to create a plane, and then uses that plane to then further his dissection. So you're going to see these stromal pocket forceps that expand and create this nice plane that you can work with. And so he'll do this 360 degrees, simultaneously cutting with his DALK scissors, and then extending that plane with the stromal dissection forceps. So this is a really nice approach, a relatively safe approach to doing a manual stromal dissection if you really want to proceed with a DALK in a patient who has some prior potential violation of Descemet's. Certainly in patients with a prior violation of Descemet's, it's not unreasonable to just initially start with a penetrating keratoplasty instead of considering DALK. But if the patient is particularly young, it might be worthwhile, say a young keratoconus patient, might be worthwhile to give it a try. And so I would certainly recommend a manual technique in that situation. All right. And we get a nice example here of what the cornea looks like when we have some residual stromal fibrils, collagen fibrils. So you see those little white strands there, especially when you've dried the posterior stroma, dried the residual bed. You can see those nice little strands. So obviously that means that you have some residual stroma there, and you can consider continuing your dissection. If there's only a very thin layer left, you could consider leaving those residual fibrils in place and just proceeding with placing your graft. Here's just another example of a different approach. This is Mark Terry doing the Melles technique here. So actually making a scleral tunnel, again marking marking that area, and then using this dissector to actually create a stromal dissection all the way through, and then cutting down to that. So lots of different approaches to doing this, to doing a manual dissection. My preference is to start with a crescent blade to do an anterior stromal debulking, and then use a pointed dissector as well as a trifacet spatula to try to remove the residual stromal tissue. The same applies if you have achieved your big bubble but still have some residual stroma. All of those same instruments can be very helpful. With regard to leaving some residual stroma, personally I find that leaving some residual stroma in the periphery is really not an issue. That image there is just describing or indicating some posterior stroma that's present still at the periphery of the bed. But if your residual stroma is not in the center, it's really unlikely that it's going to be visually significant. So you can err on the side of safety and just proceed to place some suture graft. If it is central, though, you might want to think about trying to further your dissection and try to clear some of that residual stroma. So we talked about how to remove donor Descemet's, and there are a few different approaches to this. So some folks will go ahead and just use a dry wax cell or a cellulose sponge to scrape the posterior, to scrape Descemet's and endothelium from their donor tissue. Other people will actually get their tissue pre-prepared from their eye bank for the purpose of performing DALK. And some folks will consider getting a DALK tissue as well as a penetrating keratoplasty tissue, and then choose which one to use based on how the surgery proceeds. And if there's no perforation, then to proceed with DALK tissue as opposed to penetrating keratoplasty tissue. So for those folks, it does make a lot of sense in the sense that you can potentially allow for two tissues to be generated from one tissue, as we talked about before. So you could potentially create both a DMAC graft as well as a DALK graft from that one donor tissue, which is a nice opportunity. Typically, I prefer to just request one tissue from the eye bank, and so I'll request penetrating keratoplasty tissue, and then if things have proceeded well, then I'll proceed to remove the donor Descemet's and endothelium. My preference for removing the donor Descemet's is to actually use a dry cellulose sponge to initiate the peel, but then use forceps, typically tying forceps, to then peel the residual Descemet's in one motion, like you can kind of see in that image there. What I like about doing that is that you can then verify that you've removed all of the donor Descemet's and avoided leaving any fragments in place, which can sometimes happen if you use a cellulose sponge to do the entirety of your removal of donor Descemet's. So routine post-op management for a DALK is really pretty similar to penetrating keratoplasty. If you have a perforation, you can certainly do air at the end of the case. I tend to do air at the end of most of my cases. And if there's a perforation, I typically will have the patient lie supine for about 48 hours to reduce the risk of a Descemet's detachment. I use the same drop bars regimen as I do for my penetrating keratoplasty patients. So per forte, starting at QID and then tapering by a drop every 3 months. Suture management, I approach very much the same as penetrating keratoplasty. Some folks will try to remove their sutures faster and feel that it's safe to do that. Personally, I don't mind just waiting until the 3 to 6 month period to start removing sutures, guided by topography. Certainly, one of the more common issues that we can run into post-operatively with a DALK is a pseudo-anterior chamber or a double anterior chamber. Usually this will occur only in the context of a break in Descemet's membrane, a perforation, and you have some of that aqueous sort of getting into that interface and sort of ballooning Descemet's off. So one of the simplest things you can do, as I mentioned, is just to inject an air bubble or an SF6 bubble in order to get it to reattach. Typically these reattach more easily than a DMAC detachment, especially a large detachment of Descemet's in a DALK patient typically reattaches more easily than a DMAC. One trick that I like to use, unclear whether there's good data to surround this yet, but is to use a hypertonic agent like Miro or glycerin to try to enhance the dehydration of the donor tissue and presumably enhance the dehydration of that interface and promote the adhesion of the of the recipient Descemet to the donor stroma. Another thing that you want to be thinking about is to make sure that if you do inject viscoelastic into the space after you've achieved your big bubble, make sure that you wash that interface very carefully before you place your donor tissue, because otherwise residual viscoelastic can really cause your host Descemets to not want to attach to your donor stroma. Another less concerning issue is a Descemet's fold, although it can happen in the context of a Descemet's detachment. And one approach is to try to identify these potential issues intra-op and then try to smooth them manually with a cyclodialysis spatula. That can be easier said than done, though. And so in reality, a lot of these will not present until after you're in the postoperative period. If there's a really significant difference between the shape of the host cornea, say a very, very steep host cornea with a stretched Descemet's membrane versus the graft cornea, this is more likely to happen. So sometimes it's inevitable, but if you can, you want to try to smooth this out as best you can and try to bring those folds out to the periphery so that it's not as visually significant. In reality, though, these tend not to be very visually significant, even if they are close to the visual axis. So don't be concerned about it if it is close. Interface haze is certainly a concern, though. It can cause a worse visual outcome than a penetrating keratoplasty. So you do want to be very careful about, again, rinsing that host Descemet before you place your graft, trying to remove any heme or viscoelastic that might be present. And you can even try to attempt to rinse that interface at the end of the case. And at the end of the case, you may only be able to displace from the visual axis, but that is very important to try to achieve the best visual outcome that you can. Some other post-op issues that can arise include stromal or epithelial rejection. Management, just like with a PKP, is pretty common, so you can do topical subconj or sub-T non-steroid. Interface keratitis, though, is something that doesn't occur in a PKP and can happen in a DALK. And it can be very difficult to treat those interface infections, and you may need to end up doing a therapeutic penetrating keratoplasty, although you can consider doing intrastromal antibiotics prior to needing to proceed to a therapeutic graft. If you are using air or gas at the end of the case, then you do want to make sure that that you've prepared the patient appropriately for it. So either dilating at the end of the case in a patient who's pseudophakic, or performing a pre-op or intra-op peripheral iridotomy to avoid block due to that air or gas. So let's take just a few moments to really think about, well, is it worth doing all of this additional work to get a DALK? And let's do a little head-to-head comparison with penetrating keratoplasty. So the first question that I want to look at is, do patients who actually receive a DALK see as well as patients who receive a penetrating keratoplasty? So this study involving some of my colleagues here at University of Michigan, Dr. Stein and Dr. Musk, it involved a systematic review of 481 eyes of DALK patients versus 501 PK eyes, and they found no significant difference in best corrected visual acuity, spherical equivalent, or astigmatism. And importantly, there is a higher endothelial cell density in the DALK groups, again, most likely because there is no rejection of the host endothelium in these patients. So the next question is the rejection rate better in DALK patients versus penetrating keratoplasty patients? And the answer in a variety of studies has been yes. This particular study, they found a rate of rejection of 8% in DALK eyes versus 28% in penetrating keratoplasty eyes. Those numbers vary pretty significantly from study to study and depending on the number of years of follow-up. But the trend tends to be pretty similar, that DALK tends to have a significantly lower risk of rejection compared to penetrating keratoplasty. We had mentioned before that a large study indicated just a 0.28 times risk of rejection in DALK patients versus penetrating keratoplasty patients. So just another indication that it is worth trying DALKs, again, especially on those young patients who may have a lifetime or many, many decades to consider in which they will need this graft to function. Infection is another concern. As we talked about just a few moments ago, interface infection is particularly difficult to treat and something that only really affects DALK patients. But in reality, most of the infections that occur with DALK patients tend to be associated with epidefects or suture abscesses, both of which can happen in penetrating keratoplasties as well. So if you do see an interface infection, though, in a DALK patient, you do want to act very quickly, either considering those intrastromal antibiotics, considering removing the intrastromal cap, or penetrating keratoplasty as quickly as is necessary to avoid extension of the infection into the interchamber and formation of an endophthalmitis. So the last question that I wanted to think about with regard to the comparison of DALK and penetrating keratoplasty is cost effectiveness. So I think a lot of folks are hesitant to consider DALK because they're concerned that that the cost of doing a DALK is greater because of the time that's involved in performing it and the possibility of needing to convert to a penetrating keratoplasty anyway. And so I just wanted to pass along this study looking at the cost utility analysis of DALK and penetrating keratoplasty. So as we would expect, penetrating keratoplasty was the lower cost procedure in this study, and it had a very favorable ratio, cost utility ratio of $3,750 per quality adjusted life year, which is a very, very good number for quality adjusted life years. DALK, however, had an incremental cost utility ratio of approximately $3,000 per quality adjusted life year compared with penetrating keratoplasty, which in and of itself is actually quite good. And so when we think about the greater context of acceptable quality adjusted life year numbers for various surgical interventions, both of those numbers, 3750 as well as the additional 3,000 for a DALK, are quite reasonable and would be considered by most to be cost effective. So looking toward the future of DALK, I think there are several things that hold promise for making DALK a bit more reproducible and something that we should really attempt on most of our otherwise penetrating keratoplasty patients who don't have endothelial dysfunction. So one thing to consider is the possibility of using the femtosecond laser to achieve a specific depth of trephination, which can be nice, especially if you have OCT data to guide it. It can also create a needle track for placement of your needle and or your air cannula, which is a very nice opportunity. We can get to exactly that, either 100 micron or 50 micron depth, depending on how accurate your guidance system is. Using intraoperative OCT, I think, is another important step that hopefully we'll all have access to in the not too distant future. That's going to require not only operating microscopes that have a built-in OCT capability, but also instruments that are compatible with inter-segment OCT, so that they don't create reflections that prevent us from being able to analyze the depth of our needle or cannula placement within the context of the host stroma. And then another thing to consider is the possibility of using cross-linking to strengthen the graft-host junction and prevent ectasia in some of these ectasia patients. So as we talked about, a lot of our patients who are undergoing DALK tend to be patients with ectasia, and they may be able to benefit the most from consideration of cross-linking to prevent further ectasia, especially those young patients. So just a few takeaways to summarize, and we'll wrap it up here. So DALK patients typically achieve similar visual outcomes to penetrating keratoplasty patients while having a lower risk of rejection, no open sky interval, and a lower risk of cataract and glaucoma development, which, as we said, are very relevant, especially to our young patients who have many, many years to deal with this graft. DALK is really a great alternative to using to penetrating keratoplasty in these patients, especially those who need an optical graft. And even though DALK can be more technically challenging, a variety of techniques exist to make it more reproducible. Your iBank can help you become more comfortable with the technical aspects of DALK by helping to set up wet labs for you. I really do think that advancements in technology promise to make DALK more reproducible, including intraoperative OCT and femtosecond laser trephination and tunneling. So with that, I'll wrap it up. Hopefully you all found a couple of points of information that were useful to you in that. And I'm more than happy to take some questions.
Okay, Dr. Nallasamy, we do have a couple questions for you, both from Dr. Jennifer Park. Thank you for your excellent talk. Any tips for removing residual firmly adherent bits of posterior stroma when doing manual dissection due to a failed big bubble?
Yeah, so one thing that I find really helps is to try to keep your stroma dry. So we saw a few examples in those videos of being able to visualize those residual stromal fibrils. Really, you can really only do that well when you have dry stroma. You may need to, to identify where you have those residual fibrils, you really want to dry first. And then once you've gotten into your plane, then you can think about lubricating again in order to make the tissue a little bit more pliable. As I said before, I really do like using that trifacet spatula. I find that is a really safe way to try to get into those planes. Yeah, that's typically what I find works for me.
Okay, and then her second question is, can you attempt a big bubble again once you get limbus to limbus emphysema of the anterior stroma from a failed attempt?
So you could. I typically don't, and if I've gotten emphysema throughout the entirety of the stroma, at that point I'll switch to a manual dissection technique, and I just find that to be safer. If a lot of your emphysema is anterior and you didn't remove the anterior stromal cap, then what you can consider doing is removing the anterior stromal cap, dissecting that off, so you can get down to a layer that maybe still affords you some visualization, and then you can try again. But if you're not able to get to a layer that affords you any visualization and the entirety of the posterior stroma has emphysematous, then you might want to think about switching to a manual dissection technique.
To prevent interface haze in manual DALK, have you ever used MMC on the donor stromal graft?
I haven't personally. The donor stroma. Okay. No, I haven't personally done that. I have some colleagues who do that, but it's a very reasonable thought. If you manage to get a bare Descemet's dissection, not usually something that you need to be concerned about, but it is something that's a reasonable thought. Yeah, it's really up to you if that's something that you would, if you'd like to try. I think it's perfectly reasonable. Yeah, I personally haven't tried it though.
When you started DALK, what were your most common reasons for failure of the big bubble?
Yeah, that's a great question. So for me, the most common reasons were one, not doing my dissection close enough to the posterior, to the Descemet's layer. So just sort of when I use my pointed dissector, I would sort of venture into sort of mid stroma instead of the posterior stroma, just because I was trying to be extra careful about perforation. So it just takes a little bit of time to feel comfortable and get a sense of how it feels to be close to that Descemet's and in the posterior stroma. And then to also have that comfort level with the idea that the Descemet's is a little bit pliable, and so you can you can do it by feel. So that was really the first thing. And then the second thing was being a little bit too timid with the injection of the air. So I think there's a tendency, you can kind of go either way. You can be a little too aggressive. You can be a little too aggressive in your injection, and then that can result in a perforation. I think I tended toward the more tentative side with my injection air, and so it wasn't forceful enough to generate that, to generate the bubble and remove the donor Descemet's. So those are certainly the things I think that you want to be thinking about. And like I said during the talk, I think it's a great idea to connect with your local eye bank and try to practice that on tissue. Or if you're planning to do a penetrating keratoplasty on a patient, it is a reasonable thought to try that as an alternative and give your patients kind of the messaging that you might be able to perform a DALK as opposed to penetrating keratoplasty, but it may not be possible as well.
Okay, next question from Ryan Jaber. Do you feel there is any issue with leaving the endothelium on the graft?
Yes, so I think there's a greater risk of having interface haze. It's not that you can't do it, and it's not that it would necessarily prevent the adherence of Descemet's, the host Descemet's, but I think you're also creating a potential source of rejection that you don't really need. So my preference is to just remove the endothelium. I think that it's really not a very difficult step to the procedure and not a very time-consuming one. And like I mentioned before, you can just ask your eye bank to prepare to remove the endothelium for you if you wanted to do that. And that's that would save you that step. Like I said, you can request both the DALK tissue as well as the PKP tissue if you'd like, and send back the one that you don't end up using.
Okay. Next question from Jennifer Park. Does your institution have an intra-op ASOCT? And if so, do you use that now for your DALKs?
We've trialed an intra-op ASOCT here. Unfortunately, we don't have one. We didn't end up purchasing it, but it is something that I think would be a fantastic I think it would be a fantastic addition, and I think developing, as I said before, developing the appropriate instruments to utilize with it and possibly guidance systems to use with it will be really important to making DALK more widely accepted around the world.
Okay, and one question from David Bosch. Do you anticipate DALK becoming less common with treatments like cross-linking becoming more widely available?
Yeah, I think a lot of our penetrating keratoplasty and penetrating keratoplasty alternatives are already decreasing, as I think a lot of the EBA data seems to indicate. And so I think it's quite likely that cross-linking will contribute to that. I'm not sure that we have enough longitudinal data to really definitively say that about cross-linking quite yet, but that's my suspicion. I do believe that that DALK and penetrating keratoplasty for optical reasons, particularly arctasias, will become less common. That being said, there are a lot of patients, unfortunately, who don't have access to cross-linking for any of a variety of reasons. Sometimes it's insurance coverage and other reasons, just access to care. And for those patients, unfortunately, it may be that their only option is to wait for keratoplasty of some sort. So I think there's, regardless of cross-linking's availability or regardless of cross-linking becoming an option, I think we still will need all of the skills that we've developed for DALK and penetrating keratoplasty for these patients down the road.
Okay, there are no further questions at this time. I would like to thank everyone again for joining us today. The webinar has been recorded and will be available on our website to view on demand. You will be receiving a follow-up email shortly after the webinar concludes. It would be greatly appreciated if you would provide us with your feedback on today's session. A special thank you to Dr. Nallasamy for serving as today's speaker and for providing us with your invaluable expertise on this subject. Have a wonderful evening, everyone. Thanks so much, Dr. Nallasamy.
Thank you.